There are many advantages in treating early. The first is, you could say, it's damage control, because when mental illnesses appear for the first time, usually in emerging adults, it's a very sensitive period of life because the young person is trying to establish their identity, they're trying to develop a vocational pathway with education and work, they're trying to separate from their family of origin and become independent humans. And, you know, it's a very challenging set of tasks. The brain's developing, there's a whole lot of factors there, that a lot more risk-taking behaviour perhaps, drugs and alcohol in the mix, so it's a very, very sensitive time. So intervening early can prevent a lot of the secondary damage that can occur from delayed intervention, which is really a social effect. If you become mentally ill and it's not picked up and treated effectively, then you lose your friends, you lose your job, you drop out of the educational system, you might not even finish school, and your family's put under major strain. And you might also get addicted to drugs or alcohol in the process. So picking it up early, treating it effectively, which we can do in the majority of cases, is very, very important. Well, the types of intervention that we see in early psychosis and other early intervention programs in youth mental health care are pretty needs-based in a way. Depending on the level of need and complexity of the problem, the interventions can be quite simple. They can be just a matter of a listening ear, support, reassurance, information, and maybe some problem solving. And ranging right through to more intensive biopsychosocial care involving drug therapy, more sophisticated psychological interventions, and more extensive social support and even outreach. So it's a spectrum of care. We use a staging model to actually work out, you know, what intensity to offer. So if the person's in the early or milder stages of a problem, obviously we respond. You know, we don't over-treat people, we don't offer medication as the first line. But if the problem's not responding to those simpler interventions, then we increase the dose and the expertise that's made available, and the medication then might be a second or third stage offering for the person to choose. And we have a lot of evidence-based treatments in psychiatry, and if they're delivered properly, they can really transform the outcomes for most patients. Not all patients. We still have work to do for some people who don't respond to what we already have to offer. So that's a matter for research. But in general, we're very confident we can change the course for the majority of patients. Well, if you think about early intervention, it's best to turn the question around and say, when would early intervention not be a good idea? And I think there are two situations. The first one is where you've got no effective treatments. So there's no point, in a sense, of intervening early because it doesn't change the prognosis for the patient. You just intervene whenever you get the chance to. The other situation is where the treatments that you have to offer are likely to do more harm than good. And obviously every powerful treatment, especially drug therapies and more biological treatments, but also psychological treatments, they can have risks and harms associated with them. So we're very careful in medicine and healthcare not to over-treat, and the first principle is do no harm in medicine, goes right back to Hippocrates. And so we have to balance I suppose the ambition and the proactiveness of treatment with that sort of caveat. But having said that, in psychiatry, we do have effective treatments, and they do have risks, so we've got to actually make the treatment proportional to the seriousness and stage of the problem. Early intervention in psychosis has been a phenomenon, actually, in the last 20 years in psychiatry. The treatment of psychotic illnesses like schizophrenia were completely clouded by pessimism and therapeutic nihilism. Certainly when I started psychiatry in the early to mid-80s, that was the message. Every single patient that was diagnosed with schizophrenia was told that the prognosis was very poor, that they probably wouldn't be able to work, they wouldn't have a normal life. Very hopeless message was given to the patients. But since then, we've found that if we do intervene early, if we shorten the delays in treatment, and if we deliver evidence-based care in a broad, holistic way, including psychosocial interventions as well as drug therapies, and we make those consistently available, that the outcomes are much better. And we have 20 years of evidence and 10 international meetings on this subject to really strengthen the evidence base in support of early intervention in psychosis. The outcomes are definitely better after 2 years or so, and the challenge then is maintaining those early benefits over the longer term, and that requires investment in high quality mental health services to sustain those benefits, which sadly in many locations is not available to the public. So there's a reform challenge here to make sure that this evidence is actually realised in the lives of ordinary people. The other very exciting thing is that we've been able to go even earlier, prior to the first psychotic episode, and find people who are struggling and certainly impaired functionally and suffering, but haven't quite made the threshold for diagnosis for schizophrenia or other psychotic illnesses. This is called the prodromal or ultra-high risk phase. And there are 11 clinical trials showing now that we can actually delay the onset of psychosis in this at-risk mental state that as it presents. So I think the frontier has moved, a long way forward, and the next decade will really refine this, and it'll also extend the benefits of this approach to a whole range of diagnoses in young people. With the youth mental health focus, we've begun to extend the early intervention principle across the diagnostic spectrum into other disorders. And these disorders are not discrete illnesses per se. There's a lot of overlap. And the way they emerge in the first place is usually through a mixture or constellation of different symptom patterns like depression and anxiety and maybe some substance use, some personality issues. And then you might get some warning signs of a more classical psychiatric illnesses like schizophrenia appearing. So this principle of early intervention that's been pioneered in psychotic disorders is now being applied in a more flexible way across the diagnostic spectrum. The evidence is still early compared to the large body of evidence, including economic evidence in early intervention psychosis, but it's starting to be assembled in mood disorders, in bipolar, in depression, anxiety, and eating disorders. And the journal Early Intervention in Psychiatry has been founded to really support and stimulate this sort of scientific research to create the evidence base across the diagnostic spectrum. Early intervention and a fair deal for people with mental illness, especially young people in the prime of life, because 75% of these illnesses appear before 25. This is not just a matter of scientific research and evidence. It's a matter of healthcare reform. It's a matter of human rights. It's a matter of a fair deal for people with mental illness. And that's 50% of us at some point in our life. So it's a matter of self-interest as well as human rights. And it's going to take the whole community and our political leaders and the whole society really to get behind this reform. It's something that hasn't been possible until this stage of human history, because the mentally ill have had a terrible legacy of suffering and neglect. But we're starting to see some light at the end of the tunnel here, and it's been driven by science and evidence, but it will only really change if the society as a whole demands that some action occurs.